started. Thank you for joining and for sharing your name and introducing yourself in the chat. Welcome. I know it's a snowy day, so thank you for taking time out of your busy schedules to join us. Um, we are going to get started, as I mentioned. So my name is Tracy Summer. I'm going to be helping to facilitate today's webinar hosted by Max. And for those who are not familiar, we are the Maryland Addiction Consultation Service. We provide support to prescribers across the state, as well as pharmacists and their healthcare teams in addressing any questions that you have about substance use disorders or questions about pain management. We offer phone consultation for clinical questions, help with resource information. We do a lot of education and training, like today's free webinar. We do technical assistance to practices who are expanding or implementing, let's say, their office-based addiction treatment. We do our tele-echo clinics. We have several cohorts, and also our Max for Moms program, which is our same service, just kind of targeted for prescribers treating patients who are pregnant or in the postpartum period, again, with questions about substance use disorders. We will put our information into the chat, so please feel free to reach out to us for support. We're happy to help. Couple of housekeeping items before we dive in. The credit to earn the credit in order to, for today's training, you must be online for the full duration of today's webinar, and you need to complete the evaluation within 7 days from today. That will be available if you log into your Oasis portal immediately after today's session. Please use the chat if you have any questions. We will have time at the end for questions. And then today's presentation is going to be recorded, and a copy of the slides will also be available on our website. So now I'm happy to introduce our presenter for today, Dr. Aditi Amringwala. She's an assistant professor at the University of Maryland School of Medicine, and she's training in addiction medicine and internal medicine. She is the medical director of the primary care physician and a primary care physician in the harm and recovery practice, and an addiction medicine physician in various drug and alcohol programs throughout the state, as well as the Caroline County Mobile Treatment Unit. She has worked on various projects throughout the university, as well as for Max. So thank you so much, Dr. Ringwala, for being here today with us and for taking time. I can now pass it on to you.
All right, thanks so much, Tracy. My name is Aditi Ringwala, like Tracy had mentioned. One of my roles is to be on the addiction consult service at University of Maryland Treatment Center, the shock trauma hospital. So I wanted to take this opportunity to talk about inpatient management of opioid use disorder. I know a lot of you on the call most likely practice in more of an outpatient setting. So if you have any questions or want to see how this applies to your outpatient practice, feel free to chime in and interrupt because I want to make this as engaging as possible. It doesn't have to be a one-way lecture. I'm happy to talk through things, but the focus of this talk is inpatient management of opioid use disorder. All right, let me share my screen. 1 second. Tracy, were you able to make me a co-host by chance?
I was, yeah, you should be
Okay.
able to.
Host tools. Usually it's right on my screen. I don't see it. Do you have my lecture slides by chance?
I don't, but if you wanted to send them, I'm happy to pull them up. I can also try one other thing.
Okay, because I don't see the share my screen tab that usually pops up.
Okay, I'm gonna do one
Does
other
it does it
thing.
show up by any chance when you select the more option
Let me
if it's not
see.
full screened?
More. Let me see. Let me try that. Oh, yes. Thank you, whoever that
No
was.
problem.
I found it.
Thank you, Zach.
No problem.
All right. Okay, wonderful. Thank you. So this is my lecture about inpatient management of opioid use disorder. I have no financial disclosures. So the goal of this presentation is to introduce you guys to the Addiction Medicine Consult Service at University of Maryland, who we are, why we exist, indications for why teams consult us, how we make a diagnosis, and what our treatment plans are, and our most common treatment plans, especially with buprenorphine, and then discharge planning for when our patients get ready to leave the hospital. So I'm starting out with a theoretical case to help us get through the slides. So I have a patient, Jason Bourne. He's a 34-year-old male who presented to shock trauma after a motor vehicle accident. He was found to have a urine drug screen positive for fentanyl. And so I wanted to start out with introducing the consult service. So the consult service was originally started in July of 1998, which is actually much earlier than a lot of consult services throughout the nation. Currently, I think about 60% of hospitals have an addiction consult service, and most of them are affiliated with an academic center. So there are a lot of hospitals that you'll come across where mostly the hospitalists or the inpatient admitting teams will be playing this role. They don't have a dedicated consult service, but usually when there is a consult service, it is a multimodal service with a lot of different healthcare professionals on it, because there's a lot of moving parts when it comes to an addiction consult service that aren't necessarily geared just for physicians to tackle. The purpose of our consult service is to get an addiction specific history, to do motivational interviewing, help with withdrawal management for our teams, discuss initiating pharmacotherapy and give recommendations on how patients can start on treatment for their opioid use disorder, and help with pain management, and then link patients to care post-hospitalization. So the focus of my talk is going to be for opioid use disorder, but this applies to, all sorts of substances. We get consulted on alcohol use, benzo use disorder, cocaine, cannabis. Really, we're there to help teams with all sorts of substance use, but I'm going to focus specifically on OUD for this lecture. So this is the current consult service. It consists of the nurse practitioners, and they do a lot of our the bulk of the consults because it is higher volume. And so they help manage a lot of our referrals and requests, and they know a lot of our patients because we get a lot of readmissions. We have a social worker, Jason, and he is great for referrals post-hospitalization and can help coordinate and find patients the best place to be. We have peer recovery coaches. Most of our peer recovery coaches are housed in the emergency room so they can help patients that aren't admitted get programs that they may go to after discharge. And then a lot of our teaching happens with residents that are psych first years. We also get fellows in both addiction medicine and addiction psychiatry, and then we get medical students. And those are staffed by our faculty, Dr. Welsh, Dr. Cito, Dr. Liu, and I. And so who is consulting us at university? And so it's all sorts of subspecialties. We get MICU, SICU, cardiology, pediatrics, OBGYN, general medicine, infectious disease, neurology, neurosurgery. So everyone is able to consult us. Some of the services utilize us a little more frequently and for specific questions, whereas others, really just ask us to help with discharge planning and things like that. So it just depends on their comfort level with management of OUD. And what's the indication for utilizing an addiction consult service? So there've been a few studies that compare hospitals that have an addiction consult service to ones that don't. And so this is a study back in 2025 that looked at 3 different hospitals. And it showed that patients that were seen by a substance use directed team had a better rate of initiating on treatment for OUD. It looks like about 57% of those patients were started on treatment, whereas only 25% were started if they weren't seen by a dedicated OUD team. And there was also better treatment follow-up after they'd been discharged. And there was a similar finding from a study published out in New York with a slightly higher volume of patients, where the initiation rate was closer to 11% for patients that were seen by a team of addiction consultants versus 6% for those that weren't. And then same with engagement post-hospitalization. There was better engagement for patients that were seen during admission, whether it was because they were referred to a specific provider that was, aware of their case, or if it was because of the engagement while they were hospitalized. So when do these teams try to consult us? And it's usually at the request of the patient prior to starting treatment for a substance use disorder, so that we know what is our discharge plan after they are leaving. So if they're started on methadone, we know that they're agreeing to go. They are able to ambulate, or we have a discharge plan where the methadone is going to get delivered, and the patient's aware of the requirements of an OTP before initiating. And so we can help them with discharge planning before we initiate it. We can also help with management of intoxication and withdrawal within the hospital, and we can offer motivational interviewing. So this primary team consults addiction, but what can the patient offer this team while they're waiting? And this is also something that we kind of do in the outpatient setting a lot of times, and that when a patient is going through withdrawal is to make sure we're giving them comfort meds. So like when your patient, if you're at an OTP, is starting on a lower dose of methadone, then they know they're going to be in withdrawal, offering them clonidine or Imodium or Zofran, depending on how they're doing in terms of their vitals. So that's one of the things we really emphasize with the teams, because we're not always able to get to them right away. So we try to tell our inpatient teams, please make them comfortable. And the one nice thing about inpatient medicine, unlike outpatient, is we can use opioid agonists while we're making them comfortable. So outpatient, I can't prescribe oxycodone to help them with their withdrawal, but inpatient I can. And so I can get them on an agonist therapy so they're not severely withdrawing without having to commit them to methadone or buprenorphine until they're ready to discuss it. And a lot of patients aren't really willing to have a thorough conversation because they're so uncomfortable in the hospital, not only because they're getting admitted for something that's most likely painful, such as this patient who's being admitted for a motor vehicle accident, but a lot of our patients get admitted for cellulitis and other really painful conditions, and they don't really want to talk about what is their long-term plan on their OUD when they're, miserable and in pain. And so making sure you get all the comfort meds that you feel like they need, and for hospitalized patients, getting them on an aggressive opioid regimen can help you discuss what the long-term plan is. And a lot of these patients know, but just reiterating that, hey, this is the plan for now while we're trying to stabilize you, but these medicines can't be prescribed outpatient unless you know that you have another reason that you are going to prescribe it. But like, I can't give you a short-acting agonist on discharge. So I want to get you on a dose that you're comfortable on while you're here so we can get you off the agonist, short-acting, and get you onto a regimen that you can continue so you don't have to continue using your illicit opioid when you leave. And then it's really important, especially because a lot of you guys are addiction providers, that we address patients in a patient-first language. So not using words that are stigmatizing like dirty or clean, abuse, habit. Our patients will use those languages, and like you'll see it in the healthcare setting a lot where people use words like that, but it's really important that we make sure as addiction providers or healthcare providers that we address it in a manner that we're not disrespecting the patient. And so this is a good diagram of words that you can try to avoid and words you can use in place of it. So using substance use disorder instead of someone that's an addict. Instead of saying abuse, say use or misuse, things like that that are kind of current practice is important just to establish that rapport with the patient. Um, so specifically what we do when we see patients is very similar to what you would do in the outpatient setting whether you're an inpatient provider or an outpatient, is trying to get an addiction-specific history. A lot of our services in the hospital, they're very busy, and so it's sometimes they won't be able to get this degree of in-depth discussion about all substances and social history, trying to figure out, what treatment programs they've been to before, what other substances they may also be withdrawing from. So we can focus in on that. And so that's a big part of what we do when we're seeing the patient, as well as getting a good social history. So where are they going to go when they leave this program? Who's going to help them take care of their medical needs? Are they ambulating? Can they walk to an OTP, or do they have other needs that prevent them from being able to go somewhere else? Are they housed? Are they homeless? Things like that. And then it also really helps build rapport, and I think is a really important part of their care if you can um, do some motivational interviewing and try to get feedback on what their ultimate goals are. And this is a great tool on how to do some motivational interviewing. I think Max has some, Tracy, you can correct me if I'm wrong, but I think Max also has a more in-depth lecture on motivational interviewing. Is that right?
I can definitely look back and I can reference it, and we definitely do have some resources, like some updated resources. So I'm happy to make sure everyone here has those.
Yeah, and that is really important when you're talking to your patient and trying to get change talk, because a lot of our patients are not as open to discussing it unless you approach them with a certain level of discretion. And so motivational interviewing and like making sure you're addressing patients in that manner can really help you build that rapport. Um, so how do we make the diagnosis of opioid use disorder? So inpatient, we do it in a very similar manner that it's done outpatient. We use DSM-5 and focus in on, impaired control, social impairment, risky use of substance use, and then making sure that it is meeting the pharmacologic criteria. So if they hit 2 to 3 of these points, then they have a mild OUD diagnosis. If it's 4 to 5, it's considered moderate, and 6 or more is considered severe um, based on DSM-5. So based on the addiction history obtained, this patient is diagnosed with an opioid use disorder. So what are our treatment options for opioid use disorder in the inpatient setting? So, there's 3 FDA-approved treatments for opioid use disorder: methadone, buprenorphine, or naltrexone. In the hospital setting, I have yet to use naltrexone. We very rarely, if ever, use it. If a patient is on it and wants to continue on it, it's definitely something we can do while they're hospitalized. But unlike sometimes you'll see this in treatment programs, rehabs, where they get patients completely off of uh, an opioid agonist or partial agonist, and then give them Vivitrol upon discharge, which is the naltrexone injectable. We don't ever really do that in the hospital. We're only currently using methadone and buprenorphine for the management of their opioid use disorder. And so just a little bit of a review about methadone. It's a full agonist at the mu receptor, synthetic opioid, and it's long acting and has a weak affinity for the mu receptor. So it can be easily replaced by the partial agonist and antagonist. So this means that buprenorphine, if you're giving it to someone that is on methadone at high doses or normal doses, it will precipitate withdrawal because it'll push methadone off the receptors. And same with the naltrexone, since that's an antagonist, and methadone has weak affinity to the receptors. It'll push methadone off the receptors if you give them naltrexone while they're on methadone. So that's why it's really important, so you know what they're getting before you start these treatments. So things that I think about before I start a patient on methadone while they're hospitalized. What does their EKG look like? And do they have other cardiac and pulmonary conditions that may be a contraindication for them starting on methadone? So I really try to tell patients that are on home oxygen or have cardiac concerns that may predispose them to a prolonged QTC that methadone is not a great option for them. If they are only wanting to use methadone, I let them know that, if they are a candidate now, they may not be long term. So, if they're at risk of heart attacks and they have some sort of cardiac event where their QTC is prolonged, then in the future they may have to stop the methadone, or they may be limited to how high their methadone dose can be. And so I really try to dissuade patients from using methadone if they are having any contraindications to it. Um, and then are they able to enroll and attend an opioid treatment program? Um, at our hospital, we do have a pretty good relationship with an opioid treatment program that's willing to deliver and see patients virtually, so they don't necessarily need to be seen in person. But that is not established at most universities or regular hospitals. And so a lot of OTPs, opioid treatment programs, where patients get their methadone, and that's the only place they can really get consistent methadone, require you to come in and do an intake and require you initially to be seen regularly to be able to get the methadone. And so if the patient can't physically get in, or if they don't have a program that's accepting them, then it's not beneficial to start them on methadone while they're hospitalized. So you need to have that established before you start the patient on higher doses of methadone. And then talking to them about their previous experience with methadone. Did it work well with them? Did they like going to the OTP? Did they have any contraindications that prevented them from using it in the past? Because those things were going to be probably popping up again, and seeing if that is a reason to use it or not use it in the future. And then the other treatment option that we very regularly use is buprenorphine. That's a partial agonist at the mu receptor. It's semi-synthetic, it's long acting, has a half-life of 24 to 36 hours, and it has a high affinity for the mu receptors. So like I said, it can precipitate withdrawal if you're starting them on it while they have other full agonists like fentanyl or oxy or methadone on board. So you really need to time the buprenorphine properly or dose it properly so that you don't precipitate withdrawal when you're starting patients on it. Uh, so in the inpatient setting, currently we're using two methods of initiating patients on buprenorphine. There's the traditional method that we use, and that requires the patient to be in moderate withdrawal from opioids prior to starting. Providers and patients are more comfortable with this method because this is what they've used in the outpatient setting, so they know how it works, and so they want to do what they're comfortable with. But it does have a risk of withdrawal, especially if the patient isn't giving you accurate history on when they last used, or based on how the cow scoring, if you're using cow scoring, how the cow scoring is done by the nursing staff, as well as a lot of times, I'm sure if any of you have done a home bube initiation, the patients can dose themselves to make themselves comfortable. But in the hospital setting, when there's nurses involved and orders involved, they're not able to tweak the buprenorphine by themselves. And so it can sometimes make it more challenging to do a traditional buprenorphine initiation because they may feel like they need more, but if there isn't a doctor available right away to give them that increase, the nurses aren't going to give it to them. And so that can sometimes be a challenge for patients when they're doing a traditional buprenorphine initiation in the hospital. But if it all goes well, usually the hospitalization stay is shorter, and it's quicker to start them. And they don't need to stay as long just to manage their opioid use disorder. We also do a little more complicated, a low dose buprenorphine initiation, which is much more challenging to do outpatient. And with a low dose buprenorphine initiation, we do very small doses of buprenorphine, doses that there aren't outpatient doses available unless you're using like buccal films, which actually are not covered by insurance. So there's no way to use them outpatient for OUD. But inpatient, we can use them. We can use buccal films and we can use IV buprenorphine. And so we can get very small doses. And so I'll kind of go over this a little bit later, how we do a low dose inpatient buprenorphine initiation. But the nice thing about a low dose initiation is the patient doesn't have to be in withdrawal. So it enables us to better control their pain while they're in the hospital. And a lot of times they're hospitalized for like trauma related things or infections that are very painful. And so they don't want to be in pain. And if we can mitigate having to go into moderate withdrawal before initiating, it's been really effective to help patients start on buprenorphine. It can also sometimes require a longer hospitalization stay because we have to get them titrated up to a good dose, and so it can take a couple days. Because it is a method that most patients aren't comfortable with and they don't really understand, it is sometimes more challenging to get a patient buy-in to start on a low dose buprenorphine initiation while they're still on their opioid agonist. So this is a traditional buprenorphine initiation. Um, so, you know, in this diagram, it shows a patient that is in withdrawal, and then they have a full agonist like fentanyl, and then you add in buprenorphine at a high dose, and that can precipitate withdrawal and make them in even more severe withdrawal. So this is what would happen if you started a patient on buprenorphine without waiting for them to be in moderate withdrawal. But what we're doing with a low dose initiation, which is what we're doing in the hospital, is the patient here is on that opioid agonist. So whether it's fentanyl, we sometimes use methadone, we can definitely use like oxy. Then we put in really low doses of buprenorphine, and this will displace some of the agonist, but not all of it. And we'll build that up over time. And because it's built up slowly over time, it won't precipitate withdrawal. And if anyone's interested, I can let you know what our protocol is and how we do it. But basically, we're just doing really low doses over a couple of days. And so that, you know, after 3 or 4 days of the low doses, we get them onto a regular dose, but they never have to stop their opioid agonist. And so they never have to deal with being in withdrawal. And so it's been really effective and helps us keep our patients comfortable throughout initiating on buprenorphine, which is one of the advantages of doing this inpatient. So um, just to discuss, why would you pick methadone over buprenorphine? I think similar concerns probably come up outpatient that you guys think about. Inpatient, methadone's much easier to initiate, both inpatient and outpatient. You can just start them on the agonist no matter what they're taking. Where buprenorphine, you really got to time it and figure out the dose and make sure, if you're doing it outpatient, they're in moderate withdrawal and they're comfortable enough to be successful with it. And if patients previously have precipitated withdrawal, they're less likely to want to start on buprenorphine. Buprenorphine can be obtained more easily now. And so you can get it from a primary care doctor. You can get it from an addiction provider. You don't necessarily have to go to an OTP, but if an OTP is close to you and you're okay with going to an OTP regularly, you can also get it from an OTP. And now you don't really need an X waiver for the prescriber, so it's just overall much easier to obtain, and you can go to the pharmacy and get a 3-month supply without any issues, or a 6-month supply and see your doctor if you're very stable once every 6 months. Whereas methadone requires really strict guidelines on how frequently you need to be seen and what dose can be adjusted how quickly. Methadone also has cardiac effects and respiratory depression, which we kind of talked about a little bit. One of the things I've seen a few times in the hospital now is methadone can sometimes cause hypoglycemia in patients, and so it's contraindicated in and of itself for that. And then methadone usually only comes in the formulation that OTP has approved. So like the methadone clinic I work at only has liquid. I know there's a clinic, CAM, in at Midtown that has wafers, but there aren't like different formulations of it, whereas buprenorphine can come in injectable form, films, tablets. There's formulations that are a little more citrus. There's some mint formulations. So, there's a little more, there's a differing ways patients can get the same treatment, which is nice in terms of flexibility for patients. Overall, though, methadone has been shown in multiple studies to have a higher rate of retention than buprenorphine. And so that's something to keep in mind if a patient's like, I really just want methadone. Um, you want to pick the treatment they're most likely to take. And so if that's methadone, you got to work with them. Obviously, if it's contraindicated, then that might not be an option, but, you know, just working with the patient, in terms of what they need. So, once the patient is started on treatment and ready to discharge, what are the next steps in discharge planning? And this is where social work really comes into play for our service. We have a great social worker who's aware of all our local resources, um, and can help get patients to inpatient programs or outpatient, intensive outpatient programs or OTPs based on where they live. And what their needs are, whether they're vets and they want to go to something affiliated with the VA, or if they're pregnant patients that would benefit from a program that's directed towards pregnant females. So it's nice to have that. But if you're at a program that doesn't have it, or if you're seeing someone in the outpatient setting, um, SAMHSA has a great website that can help. Um, it's called here, findtreatment.gov, and you can just put in the zip code for your patient and they'll tell you, and there's some like parameters, like is it outpatient, is it inpatient, do they need psychiatric care, do they not? And you can click on it and it can tell you all the local programs within your vicinity. And what we tend to do is try to call the programs and see what their intake process is, if they're accepting patients, when our patient can come. And so we try to do some of that discharge planning for them before they leave, so they have a good transition from their hospital to where they're going. I also really try to push the team if the patient is on buprenorphine to give them a week or two of medicines. So if something happens post-discharge, they have a little bit of a buffer to get to the clinic they're going to. Recently, our hospital started a program where our pharmacy will discharge a 3-day supply of methadone. So if we discharge a patient on Friday and their OTP doesn't open until Monday, they can still get 3 days of methadone so they have time to get to their OTP. Or if they're going to a new OTP, they have time to do the intake, which is really great because I think as of a year ago, we weren't legally allowed to do that, but now um, I think the DEA now lets hospitals and outpatient clinic, or I think it's hospitals specifically and emergency rooms, discharge patients on methadone. Your hospital just has to have a protocol for that. So that's nice because that can help prevent a patient from staying in the hospital just for their methadone. Um, and then I just kind of wanted to discuss what we think about when we're trying to decide if a patient needs to be inpatient versus outpatient. So the rationale for inpatient treatment, if a patient is, living in a tent and going to go back to that tent where they're using, they may be better off in an inpatient setting. So we really try to promote them to go inpatient. They can get more services there. A lot of times social work can help them with housing, or they may be able to transition to sober living, and stay for a longer time until they get stabilized. The one thing I really do stress with the inpatient teams is sometimes they use outpatient addiction treatment as outpatient, like acute care rehab. And unfortunately, inpatient treatment programs can't do any nursing, or I mean, most of them cannot do nursing. Sometimes they have challenges with wheelchair bound patients. So we really have to find them specific programs, but like wound care. So like trying to stress to the inpatient teams that this is not rehab, like physical rehab. This is addiction rehab. They usually have to go like 8, or I don't know specifically, each program is different, but they usually have to do hours and hours of rehab at the program. So if they're not able to do that, it's not a good idea to send them to this program because they're not there for their physical rehab, they're really there for their addiction rehab. Um, I also, things I think about when I'm deciding if a patient would be better suited for outpatient treatment. is, if they have a stable place to live and a supportive environment, the nice thing about intensive outpatient, which tends to be about 9 hours a week, is they can build the skills they need to manage their addiction in their home environment so that, when they leave, they are not at high risk of relapse because they're already in that environment where they were previously using, or they have to use the skills that they've acquired every day when they're at their program at home. So it isn't as drastic of a transition from them for them. And so sometimes they do just as well doing intensive outpatient that they would inpatient if they have the social infrastructure to be somewhere to do intensive outpatient. And so I don't think we necessarily have a preference. It's really just about what works for the patient. And if the patient has a social infrastructure, I would actually try to get them to an intensive outpatient program. And you kind of talked about this. And so that's kind of the overall big picture for inpatient management. I'm happy to discuss more. I think there were some, I don't know, Tracy, if there were any questions or if anyone has anything they want to talk about
There
as it
were
goes over.
some questions and comments in the chat.
Yeah,
I'm
let
happy
me,
to share them. So
yeah.
one person asked, could you share the protocol you use with your patients for low dose initiation with buprenorphine?
Yes, so it's very individual. Am I still sharing? I can't tell. Sorry.
You are not still sharing, so we
Okay.
just kind of see your general
Okay.
screen.
Yeah, so it's very patient specific. The protocol we use is it depends on what our hospital has in terms of formulations, because a lot of times we're out of IV buprenorphine and we only have the buccal formulation. But usually when we do have IV buprenorphine, we typically use zero point 0.1 Q 6 hours for like the first 4 doses. And this can vary by the patient. So we use zero point 0.1 or 0.15, and then we increase it to zero point 0.3 for the next 4 doses, so the next 24 hours. And then once they're up to zero point 0.6, which we do for another 24 hours, that's the equivalent of 2 milligrams oral. And then we'll switch them to the oral, which will keep going while they're on, and all of this, they're on their agonist therapy. So whether it's oxy at 20, Q4, Q 6 hours, or they're on a low dose methadone, whatever it is, we keep that going. And then once they're up to 2 milligrams Q6 for 24 hours, we stop the agonist therapy sometimes. Sometimes we keep it going if they have a lot of pain, and we switch them over to 8 BID of buprenorphine, and then we'll go up from there. So it really just depends on the patient and how they're doing, but we do try to check on them every day. So if they're starting on 0.1 or 0.15 and they're concerned about withdrawals or they're not doing well, we can adjust their agonist therapy and maybe slow down the titration. Or if they're like, hey, I gotta leave in 2 days, you gotta get me on this, then we'll speed it up and try to get them stabilized more quickly. So it really just depends on the patient that we're seeing and how quickly we see them. So there's a question about low dose buprenorphine not being covered by insurance. Is it covered in the hospital? So what I was referring to there is the Belbuca, the oral buprenorphine that comes in low enough doses, which we use in the hospital. And yes, in the hospital, Belbuca is covered. But if, like, say, I was seeing someone in my OTP and they wanted to start on buprenorphine, but their methadone dose was at 60 and they want to do a low dose initiation, I couldn't prescribe them the Belbuca because the insurance only covers it for pain. And so I can't, if they have opioid use disorder, I can't justify it because it's illegal. Um, Sometimes what we'll do is I have had some success, cutting up films of 2 and making them really low, but that really involves, close follow-up and a commitment from the patient to really want to start. I have a hard time convincing patients to do a low dose initiation, but if a patient knows about it and is very committed to it, I have had success doing an outpatient low dose initiation, but it really has to come from the patient themselves.
Thank you so much, Dr. Rinwala. If
Mhm.
anyone else has any other questions, please feel free to put them in the chat or you can unmute because we do have several minutes for questions. So please ask away.
I do not have one written up, but there are a lot out there. And you're welcome to look, and we could probably send you, I think, do we have a one pager on some of them?
I can double check if we have a one pager. I know we do have some one pagers and materials that is very similar, and we do have a webinar kind of specifically on this as well that we can be sure to send everyone
Yeah.
as follow up from today.
Yeah, but I mean, so we have a protocol in the hospital that we use, but it's very similar to other, and I'm happy to, there are definitely articles out there about low dose buprenorphine protocols. I think they're pretty much used now throughout the nation. And so just finding one that works with your formulation that you have on at your hospital's formulary. And there are some for outpatient as well. So if you're looking to figure out what to do outpatient, there's a few. But what I have found in my outpatient practice is it really just comes down to patients that really are committed to wanting to do it and having the ability to follow them up closely. Those are kind of the two rate limiting steps to being successful in the outpatient setting. What about considerations when people are on treatment and have an accident? Um, yeah, so that's a good question. It just depends on the patient. So if I have a patient, and they're about to go into surgery and they tell me they want methadone, then you can use IV methadone. And usually the dosing is like half of the oral. So if you're going to start them on 50, you can just do 25 IV. Um, I don't, usually what I'll do is, if they're like, no, they want to do buprenorphine, I'll wait to start the low dose bup initiation until after their surgery because I don't want to complicate things for them, unless, it's gonna, I just want their pain to be in good control before I do a low dose buprenorphine initiation because I don't want any confusion. I don't want them to think the reason they're going into pain is because of the buprenorphine. Most likely it's just because they're in pain from having inadequate pain management and not necessarily because we're precipitating withdrawal. But yeah, methadone PO can be given IDV if that's the question. It just has to be half the dose based because of the bioavailability of IV versus PO. I don't know if I answered that question, but feel free to ask more. What if they have a long-term injection? Sorry, I don't, what if they have a long-term infection? Is that the question? Okay. You should do the response.
Like they've been on something
Yeah,
like an injection, like to
like
help them
fentanyl?
with it. No, not like fentanyl, but something to help them with a treatment.
Oh,
Like,
like Sublocade?
yeah.
So the question is, what if they're on Sublocade and still having pain? Because
No,
they're,
let's say they're on Sublocade, they have a car accident, they've broken their arm, they're going to go to
uh-huh.
surgery. What do you do?
You can just use opioid agonists. So you don't have to worry. You can have patients on buprenorphine and an opioid agonist. The trouble starts only really on initiation. So like that's when you can precipitate withdrawal. If a patient is not already on buprenorphine, that's when you can precipitate withdrawal. But if a patient is in the hospital on buprenorphine like Sublocade or Brixadi, you can just use whatever you were going to use, Dilaudid or um, oxys to help them with pain control. Those will still be effective and they won't precipitate withdrawal for patients that are on injection.
What about Vivitrol?
The Vivitrol is a little more challenging because it is going to block the receptors. And so that's what I warn my patients about before I do start them on naltrexone. I tell them, hey, you are getting a medicine that if you use any opioids, they're not going to be effective. So, if you're on and you start using fentanyl and you're on naltrexone, the whole point of it is it's blocking your receptors. So it's not going to work. That also means if you need surgery, the naltrexone is blocking any opioid. So then you're going to have to figure out other forms of pain control because you're basically blocking all their opioid receptors. So I think that's a conversation whoever is injecting them with Vivitrol needs to have with them before so they know what they're committing them to.
Thank you.
There was another question in the chat I
Oh, yeah.
see. Is it
Normal.
normal for a patient to be on Suboxone for more than 10 years, even though they haven't used opioids in over 5? Just asking because I have a client who is just wondering if this is normal.
Thank you, Tracy.
Yeah.
So yeah, that is completely normal. And actually, that means they're doing really well. What I tell my patients is, I guess I have a couple different discussions with them. I say, hey, how are you doing? Are you comfortable taking it every day? And if they're like, yeah, it's going well for me, I don't want to make any changes, I never force them to change. Because we know if we ask patients to stop or make them stop, their rate of relapse is like 90%. So I never want to force anyone. But if a patient's like, hey, I've been on this for 5 years and I haven't used and I'm doing really well, can I stop? I will work very closely with them to taper very slowly. The other things I really like to talk to them about are how are things going with the rest of your life? Do you have a social infrastructure? How is your mental health? Are you doing okay or is stress causing you to want to relapse? Do you have ways to cope with life? Because, if you start tapering them down and the behaviors that initially triggered them to use are not actually addressed, they're just going to relapse and use again. And I have had patients that go down significantly. I've had patients that stop, but usually those patients, their lives have changed dramatically from when they were using. So they may become housed, they may get, in other relationships, have their mental health addressed. So all of these things that initially may have instigated their relapse or use are addressed. And then also having that discussion where, if things get out of control, even if you're 2 years out from your last buprenorphine, if something happens, you lose a loved one or you lose a job or something and you relapse, you need to get back into treatment because this is a chronic condition. We don't have a cure for opioid use disorder. Like, no medication I'm going to give you is going to prevent you from never having to use opioids again. So we can get things under control. We can even taper you off, but that doesn't mitigate your ability to relapse, unfortunately. And so just having that discussion with them. And then the other thing you could try if they're interested in like really want to be off buprenorphine and you do it, you could also, once they've tapered off, you could also offer them Vivitrol at that point and be like, hey, maybe you want to think about Vivitrol. And that way, if something were to happen and you were to relapse, it wouldn't be effective and you'd have this protection to be able to not have to relapse and overdose. Because that's the other thing. If they were to overdose and stop, the potency of the illicit opioids out there right now, 1 or 2 doses of fentanyl could kill them if they don't have tolerance. And so making sure they know that when they've stopped their treatment is really important because, you could just have one episode when you're not tolerant and think you could use what you had used previously and it could kill you. So I guess that's a really important discussion to have.
Thank you so much. Again, if you have any other questions, we do have a little bit of time. Please feel free to put it in the chat or you can unmute. And I'll take this time again just to go over the process for earning credit for today's training. We will put the link to the Oasis portal into the chat, but you'll be able to go back into your portal. You'll have to use your own login and all of that information, but you can go into your portal and you'll be able to access your evaluation. And you can do that directly after today's session. And you do need that in order to get your CE credit, whether it's CME or CEU. And we really do value on the feedback. So please take the few minutes and complete that evaluation. And then you'll be able to access your certificate also in your portal as soon as you do your survey. And if you have any questions or any kind of issues, please don't hesitate to email us. You can email the Max Training email, and we are happy to help to troubleshoot any tech issues with getting your certificate. I'll give another plug for Max. If you have any questions, if you have any clinical questions, you can call our consultation warm line. Our team is happy to help. If you have a practice, and your practice and you and the other prescribers there, are interested in expanding your office space addiction treatment or kind of implementing things, you can also call us and we can have our technical assistance team certainly help you, especially as today, we've been talking about protocols, etc. If you have any questions about that, our team is happy to help. We do have another webinar that the information is on our website, but next week we do have another webinar on pain management. So you can, if you are not already enrolled in that, it's on March 5th from 12 to 1. You can enroll, another great opportunity to get CE credit. If you have any questions, please feel free to put them in the chat. Thank you so much, Dr. Amrinwala, for taking the time today to present. I think it was a great presentation, as always. I'm happy to stay on for another few minutes if folks do have questions.
All right. Thanks, everyone. Have a good day. Take care.
Thank you. And if you have questions after the fact, if you think of something this evening or even tomorrow, you can call us, you can email us anytime, and we can definitely get that question to our consultant, to Dr. Amrinwala, or if there's a different consultant who can answer your questions. Our team is happy to help overall, but I will stay on and leave it open for another couple minutes. If anyone does have questions or even kind of programmatic questions or questions, about earning credit, again, you can go into the Oasis portal. Thank you so much, Marcielle, for putting that link into the chat. You can go directly into your portal, do your login and your password, and you'll be able to access that evaluation. You do need to complete that within 7 days, and then you'll be able to get your CE credit. So to get your CE credit, you have to complete that survey. And then, of course, we really do value and appreciate the feedback. So thank you for taking the time to do that survey so we can look at that feedback, and it just helps us improve our trainings, improve our program.